Good morning, everybody. Welcome to another AFR EMS case study. My name is Chris Ortiz. I'm the EMS Chief for Albuquerque Fire Rescue, and as always, joined by Dr. Kim Pruitt, our Medical Director.
Hi, Chief.
Welcome, Doc. And also joined today by our esteemed 7-8, Captain Rob LaPrice.
Thank you, Chief.
So we have an interesting case, a little bit different today, is because the provider who submitted this case to us couldn't make it today. So the three of us are going to kind of discuss what was documented in the chart and have some discussion around that. The call was around a dystonic reaction, which we a lot of times learn in paramedic school, but may go a length of our careers without actually seeing one in reality. And it sounds like the crew did a great job as Lieutenant Javier Renteria and his team at Station 9, who was able to successfully treat this patient. So did a great job. We want to highlight that. So it sounds like Rescue 9, Engine 9, they were dispatched to a 12 Delta. They went to a parking lot on Lomas, and it was around lunchtime. And they found a 53-year-old woman who was laying supine on the ground with her neck, arms, and legs very stiff in a locked position. It didn't appear to them that she was actively seizing, but obviously it appeared abnormal. Her friend had called EMS on her behalf, said that she had normal cognition, good GCS 15, clear airway, nothing really going on other than the abnormal presentation, right? So he took the time. Sounds like he slowed it down. This isn't an active seizure, so we don't have to jump and treat that, but let's get a little more history on what's going on with this patient. So looking at his initial exam, got some vital signs. They were relatively stable, 85 for a rate, 147 over 82 for a pressure, satting 97%, good blood sugar, which we're always looking at in our seizure patients. And the history that was kind of provided by the friend that she did take some medications for anxiety, and then she had a history of Parkinson's disease. It says her muscles had been locked up for about 10 minutes, and the friend had tried to give her Ativan prior to our arrival, but there was no relief from that. It had happened before to her. She hadn't gotten better with Benadryl. So that, in my opinion, probably triggered him in that this is potentially a dystonic reaction. And Doc, I'll kick it over to you if you want to just describe an overview of what you see with dystonic reactions.
Yeah, so dystonic reactions are typically in the setting of patients who've recently had a medication change or are on psychiatric medications, and it interferes with your acetylcholine and your dopamine receptors, so the neurotransmitters that have to do with movement. And if they're recently changed, sometimes folks can get this really painful, I call it like locking up, and you can't really predict which muscle system it will be. Sometimes it's in the neck, sometimes it's the face or the eyes, sometimes it's the arms, and it causes a lot of pain. And I can see how it could maybe look like a seizure, but there's not the typical rhythmic movement that you would expect. It's a painful locked up muscle. And it can be precipitated by either walking or exertion, or even sometimes drugs or alcohol can do this as well. And I suspect with this patient, since she had Parkinson's, she's already got some kind of baseline abnormalities in her acetylcholine and her dopamine receptors and the things that regulate her movement. And you add on maybe she was in a parking lot, maybe some recent exertion, or her psychiatric medications may have precipitated this, would be my suspicion.
So if I'm on scene at this call, it doesn't appear to be a seizure. I'm stuck. I don't know what to do. Maybe I don't have that friend there that says, hey, Benadryl's worked in the past, but starts zeroing me in onto a dystonic reaction. I pick up that phone. My first call is all the way to 7-8 if I haven't seen anything, right? So talk us through, like if you're 7-8, you get this call with your experience. What have you seen with these types of reactions and how to treat them?
Gosh, these can come in as seizures, allergic reactions, all kinds of different coding, because no one sees it that much. Even lay people, they don't know what's happening. I think what Javier and his crew did that made this call so successful is they slowed it down. They realized that she is hemodynamically stable with stable vitals. They got a little history. And if you try to get history, a lot of times you'll get it. They figured out she was on this medication, which is one of the EMS, right? I always think Thorazine, Compazine, Promethazine, all the EMS. And I know this may not be completely accurate, Doc, but a lot of the psych meds are EMS, and you need to be aware of this. And I think that's what made them so successful. They slowed it down, and they figured out how to treat it. And they didn't panic. They didn't just throw her in the truck and get scared. So I love reading this case. It's really good.
And vital signs are vital, like we always talk about. And the physical exam was key. He noted that there was no signs of trauma. Everything looked normal. Vital signs were pretty stable. Lung sounds were clear. No history of seizures that anybody alluded to. So I think as soon as he zeroed in on hearing that the Benadryl had worked in the past, that's where their course of treatment went down. So sounds like the next step was to establish an IV. They gave 50 milligrams IV of Benadryl, and that successfully reduced those patients' contractions from an intense episode to almost no pain and no discomfort, to the point where she was able to stand and walk over to the passenger seat. So did an absolutely fantastic job. And then we had an interesting situation to where after she was treated successfully, she said, "I'm good. I don't want to go to the hospital by ambulance." So talk us through on the MSEP side of what you would want to hear from us. What are the things you would want to know? How can we paint the picture to say that this person is appropriate to be able to refuse?
Yeah, this is one of those really satisfying calls where the treatment is instantaneous and makes people feel better, which always makes me feel better when I can help someone else feel better. And so when we're thinking about a refusal of transport, there's usually two things I listen for. One is there a life threat? And so I always ask about vital signs because those are vital and they'll paint a picture for you. Hers were very stable and it sounds like she's already feeling better. And I didn't, on this, if I had gotten this call, I would say, okay, well, I'm not exactly hearing a life threat. And if I don't hear a life threat, then it's probably okay. If I do, or I'm suspicious of one, or we just don't know, that's where I start to dive into patient's capacity. So does this patient truly have the ability to understand what's going on with them right now? The risks of refusing. Do they, if I think there's a life threat and they're wanting to refuse, do they truly understand that I'm worried they may die if we leave them here? And if they can understand that, and they have that capacity, then that's their right. You know, sometimes people, they're allowed to make bad decisions for themselves. Our job is just to talk them through the risks and the benefits. And so this lady, in my mind, we had addressed her presenting complaint, made it better. Don't really hear a life threat here. And then it sounds like she had the capacity to understand, was very clear on what was going on and what she wanted. And
I bet she was very thankful.
yeah, yeah.
And I think that, so a lot of times, as we know, like the dispatch coding is only as good as the information that comes from the caller. And we know that historically seizures tend to be a catch-all for a lot of things, right? If somebody's presenting abnormally, a lot of times they'll get called in as a seizure. We see a lot of cardiac arrests that come in as seizures. So if you're in that mindset of the seizure coming, but you get there and it doesn't really fit what the history and the assessment that you're getting, what are some of the things that they would look for, Rob, to know that this potentially is a dystonic reaction?
So I always learned this, and I know now we call it acute dystonia. I always learned it as extrapyramidal. And what that means is outside the normal nerve pyramid. It's different. It's uncontrollable contractions, I think, Doc, correct?
Mm-hmm. Yeah.
Anyways, it can present as neck movement, mouth twisting, kind of a turned face, stiff hands, hands clenched. If you're not astute, you'd almost think at first glimpse it could be a stroke too, stroke, seizure. And then you just have to recognize that they're stable, they're decisional, and then start digging into that history. Important thing I always try to remember is a lot of homeless people, a lot of psychiatric homeless people. If you dig in their bag or talk to them or try to look for prescriptions, a lot of times you'll find a prescription for Cogentin or it's called benztropine, and it's an anti-Parkinsonian. It works almost like Benadryl. A lot of these people can't afford to fill it, so if you look even deeper, you'll find the blister tabs of Benadryl they get from Walgreens, the pinkies, the 25s. And then that should cue you to, like, this could be extrapyramidal or acute dystonia. I just think it's important to dig around a little bit.
Yeah. I think this case really emphasizes the importance of, once you've done your initial ABCs and your primary assessment, the importance of taking a history, asking about, has this happened before? What medications are you taking, including over-the-counter medications, and really helping you nail down what's the right thing to do for this patient, because it can be confusing. And then once you figure it out, you can really have the ability to help them feel better.
I think this is a case where you could use your AEIOU tips, mnemonic, to figure out, like, is this poisoning? Could be medications can be in that area. Is it a stroke? Probably not. And you can narrow it down and then just dig that history. It's super important.
And if that's our thought process, pretty low risk, and assuming they don't have an allergy to Benadryl, that to administer it if we don't see any results, then obviously we would encourage them to be transported to the hospital.
Right. If it doesn't get better, then of course they're probably still uncomfortable at that point, or something else is going on, and they would probably need to be evaluated.
Kim, for this kind of reaction, acute dystonia, Benadryl usually is pretty effective, correct?
Yes.
Like, if it is that,
that's the problem,
Benadryl will solve it.
You'll see immediate effects.
Mostly IV Benadryl.
Yes. Yeah.
Okay.
And the other just little thing to know about IV Benadryl is it does make you feel a little bit high. So if you get somebody who's requesting IV Benadryl, I usually, before I offer it, make sure that I'm really seeing the signs and symptoms of acute dystonia before I give it, just because it does have that potential for abuse.
That's a great point. And for those situations like that, if a patient is requesting a medication but nothing in their presentation is showing, then a lot of times we can encourage them to try to be transported before we administer anything, so we don't encounter I'm going to get the medication, then I'm going to immediately sign a refusal.
Exactly. So you really want to see that painful, it's a kind of a distortion of a big muscle group that's very painful and a pretty acute onset that you're looking for.
So, like with everything, this is in your history, and this is with a good assessment and a calm assessment.
Yeah.
And good vital signs.
Exactly.
And last, sorry,
I
Doc,
was
go
just
ahead.
going to say, Javier always does a very good job with his medical history.
Yeah,
and
it's a very great job.
His medical problem solving.
Yeah, and the call was documented excellently, so was able to paint a picture of exactly why they made the decision they did. So he did do a great job, him and his crew. Last question I have is, obviously the initial treatment of Benadryl resolved the issue. How often do we see where they'll have a relapse into that same issue happening again, or is there a course of treatment that they should follow moving forward if they choose to refuse?
So typically it is associated with a medication change, so it will be important to follow up with their prescriber for their psychiatric medications. We know that certain things precipitate this type of reaction, so a recent medication change can actually do that. So it may just take some time for the new dose to settle in their body to get used to it. But other things that can precipitate it as well: physical exertion, walking, alcohol, cocaine or other stimulants, anything that kind of can, in addition to the psychiatric medication, change the neurotransmitter that is involved with movement can precipitate
That's
this.
funny, Kim, that you mentioned like a recent medication change. I was thinking back at my last one like this, and I had a female patient who was just placed on a compensine suppository for nausea. And she was all twisted up in her house when we got there. And we got that history. We figured out she's on compensine. We were able to give Benadryl. And she was transported because I think she was newly pregnant, like first trimester stuff.
Yeah.
But interesting.
Yeah, it's usually, I'd say most cases of acute dystonia happen within like 96 hours of a recent medication change.
Oh, that's good. Great information.
Yeah, good to know. Awesome. Well, thank you, Rob. Thank you, Doc, for
Thanks,
discussing the case. Thanks to Lieutenant Renteria and his team for submitting. We really appreciate the work that they did, and they did a great job on this call specifically. If you have an interesting case that you want to come in and discuss with us, or just have us discuss on your behalf, feel free to submit those. We have the SharePoint site where you can make the submission, or you can reach out to the 7-8 or any one of us. Until then, we'll see you at the next case study. Thanks.